Good afternoon, everyone, and thank you for joining this session as part of Digital Health Week. Today we have Anne Madwani and Lynn McNeely presenting from CIHI on standards from point of care to health system use. I think that everyone who's registered is now on the phone, so I'd like to just do a few housekeeping notes before I turn it over to Anne and Lynn. Again, this session is part of Digital Health Week, and if you'd like to learn more about Digital Health Week, we would encourage you to visit betterhealthtogether.ca to take a look at some of the other sessions and other social media events that are happening in celebration of this event. The link to that site, again, betterhealthtogether.ca, but it will also be displayed at the end of the presentation. Another quick housekeeping note, I will say it again and again, so I appreciate your patience. Please do put yourself on mute. If you would like to ask a question, we are taking questions via the QA panel on your participant panel, so feel free to type it in to the host or to everyone if it's a question that you think everyone would benefit from, and we'll stop intermittently throughout this presentation to take some questions. If we don't get to your question during the time we have allotted to end at 1:30, we'll send out answers to the questions a little bit later on this week. Does anybody have any questions before we get started? Again, please put yourself on mute. And I'd like to welcome Anne and Lynn as our presenters today. Thank you very much.
Thanks, Tasha. So thanks, everyone, and welcome to our presentation on standards from point of care to health system use. So Lynn and I are going to be going back and forth and speaking to you a little bit about CIHI and our work with data standards, and then we'll be focusing a little bit more specifically on data standards in ambulatory care and continuum of care and the work that we're doing in this space. And lastly, we'll talk about the potential for interoperability in the future. So to get us started, I wanted to give you a little bit of background on the Canadian Institute for Health Information, or CIHI. Our vision is better data, better decisions, healthier Canadians, and our mandate is to deliver comparable and actionable information to accelerate improvements in healthcare, health system performance, and population health across the continuum. This is a mandate that's going to come into effect as of April of next year. So I'm going to turn it over to Lynn, who will take you through the next couple of slides, and then I'll speak to you a bit more about ambulatory care data standards.
Great, thanks, Anne. So here we're looking at that CIHI actually gathers data from across the healthcare system, and just under that first bullet, you'll see this data is captured within 30 databases, and there's some examples there. The first two sub-bullets indicate some of the healthcare settings we collect data from, and below that are other facets of the healthcare system. So you'll see patient experience, and that's actually our newest database, along with information gathering around pharmaceuticals, workforce, so health professional workforce, health spending, and we also capture financial data such as the MIS guidelines. Not only do we capture this large volume of data, but we also do it extensively across Canada. So right from coast to coast and up to the territories in some circumstances. And what we're looking, how we're looking to benefit the healthcare system with this is inform those health care and health system decisions that are made right from point of care up to health system use. So here we're showing some examples of what's actually in those databases. So this is CIHI's base of our base work around data standards, and we are the leader in national data standards. So some examples of those are the classification and coding standards. We develop our own case mix standards, so CIHI actually developed the CMG Plus case mix grouper along with the resource intensity weights and the case mix groupers. The RUG is an example of a standard that we support. So it's a case mix system that's generated from the interRAI standard, and we'll talk more about that later on in our presentation. But here's an example where CIHI sometimes is the producer of the data standard, but sometimes we also partner with other organizations, and we support the standard and maintain the standard for those organizations. And what that allows us to do is to be a leader in producing that high-quality comparable data and actionable information. And I just want to point out, Anne had highlighted what our mission statement is, and that's new. There's a new piece to it. So we've also always been that leader in comparable, providing comparable data across the country, but we're also moving into that actionable, so the information can be actioned. And here's an example of how some of that standardized information can be used, right from point of care up to those secondary uses that qualify as health system use. So that first component is looking at how you can provide direct client care using the information, the standardized information. And then you move into those aggregate types of decisions you're going to support using that same standardized information. So it's that adage, collect once, use many. So the information can be used for clinical program management, health system management, so you're looking at maybe using the information to support decisions affecting transitions between different sectors. It also supports public health, and of course, that's circling back to the research, which then improves the standards in the first place that we're collecting. And now I'm going to pass it on to Anne, who's going to talk more specifically about one of those standards, NACRS Clinic Lite.
Thank you, Lynn. So as Lynn said, I'm going to be speaking to you about the data standards and the work we've done in the ambulatory care space. But before I do that, I'm going to provide you with a bit of background information on one of our data holdings, the National Ambulatory Care Reporting System, or NACRS, and this is where we house some of that ambulatory or outpatient information. So NACRS is a data collection and reporting system for emergency departments, ambulatory or outpatient clinics, both in the hospital and the community, as well as day surgery data. It provides information on, it provides timely and comparative information for local planning and decision-making purposes, as well as for health system accountability and improvement. And it provides basic clinical and operational patient-level information on the number of visits, population served, as well as the reasons for health services. There's a lot of data in it that can be used for a variety of purposes. And the records in NACRS are patient and visit specific. So just a bit of background around the amount of data that's in NACRS. So in the last fiscal year, it processed over 21 million records, and 8 million of these were relating to ambulatory clinic visits across the country. So there's 4 main types of information within NACRS that makes up the ambulatory care data standard. There is patient information, so things like date of birth and health card number, administrative data, so registration and disposition date and times as an example. There's clinical information, so that relates to the diagnosis and the interventions, and it's mapped to ICD-10-CA codes and CCI codes that Lynn had mentioned in the previous slide. And then there's service-specific data, so CTAS levels and physician initial assessments. So NACRS it has a modular design, and it's designed to support different record types. So as I mentioned, there's ED data, day surgery data, as well as clinical data. There's different data collection and flow options, which I'll speak more about later. And it does have the ability to accept early or partial records, which makes it a flexible data holding. It can be used to capture data from existing e-health or digital health information systems in an automated manner, or it can support information collected and coded by health information staff. And the idea is that it can be leveraged without building any new data collection tools at the local level. So why the focus on ambulatory care data? Healthcare in Canada, as you all know, is shifting. So we're seeing movement from inpatient care to ambulatory or outpatient care and hospital-based ambulatory care to a community-based ambulatory care. And there's more integration across this continuum of care. And we found that most jurisdictions do have summary information on the ambulatory and outpatient space, but there is a gap in terms of clinical level, operational, quality and utilization data on ambulatory care. And that's where the NACRS Clinic Lite comes in. So NACRS Clinic Lite is a low-cost, low-burden submission option in NACRS. It's suitable and customizable for many clinic types across the continuum of care. It allows for rapid onboarding, and it provides valuable information for healthcare organizations as well as ministries. And I'm going to get into the details on each of these 4 points in the next few slides. So we'll start by focusing on how it's a low-cost, low-burden option. So there are a number of facilities that are already submitting to NACRS, and this is their emergency department data as well as day surgery data in some cases. And those facilities can leverage those existing workflows and processes and infrastructure to submit data to Clinic Lite. Of course, the idea behind this is that a number of outpatient clinics as well as community-based clinics have limited technical infrastructure and software and processes to expand and collect data on new clinical domains. So we try to ensure that this would be as low burden as possible. And one of the ways we do this is we try to source data as much as possible in an automated manner from existing information systems. We've made NACRS Clinic Lite quite customizable as well, so it can be used for hospital-based as well as community-based clinics. It's quite generic, so it is designed to support any clinic type, and it can be customized. And I'll get into how it can be customized in later slides. And the main way to do this is through the use of special project fields. So this is additional domain-specific data that we work with clinic types to define that's not already captured in the core Clinic Lite record. And so this data can be used to capture specific and localized needs, and it can extend that data that's available in the core part of the record. So we have tried to allow for rapid onboarding as much as possible. So the idea is to implement Clinic Lite as a byproduct of other information systems or e-health solutions. We do provide clinic or service domain-specific pick lists. So these are lists that have been mapped to valid ICD-10-CA or CCI codes for diagnosis and interventions to really minimize the manual coding and data collection burden that's associated with submitting those data elements. And the data requirements are or should be incorporated into existing information systems and workflows wherever possible to, again, reduce the manual data capture and retrospective coding. And lastly, it can be used to provide some valuable information to improve the quality and resources as well as for access efficiency and efficacy gains. So the data can be used to support ambulatory care planning, evaluation, and management, as well as capacity planning in support of health system funding reform. And a little bit later, we're going to walk you through an example of how the data in NACRS Clinic Lite can be used to support these functions. So I'm going to get into a little bit more information on the ambulatory care data standard, so the NACRS Clinic Lite data itself. There are 17 mandatory data elements available in NACRS Clinic Lite. This is much less than the 50 that are required in a fully coded NACRS Clinic record, and again, that's to ensure that this option is flexible while still capturing the data that's relevant for the ambulatory care space. So the data, the mandatory data elements, as well as the many optional data elements that are still available through NACRS Clinic Lite, can be used to answer questions such as who the patient is, where the patient is from, what brought the patient to the clinic, what was done to them, who provided the service to them, when and where, and when the patient left and where did they go. And again, we'll provide you with an example of the patient and really try to bring some of these things to life a little bit more later on in the deck. So to give you a bit of a visual around the NACRS Clinic Lite data elements, the mandatory data elements, the 17 that I had mentioned on the previous slide, are identified in the blue boxes on this slide. All of the optional data elements are in orange, so all of these are available to enhance the data that's submitted to Clinic Lite and learn more about the patient, the services provided, et cetera. and you'll see at the bottom there that there is the ability to collect information for special projects. So this is used to further customize the records that are submitted. And just to mention, there are two options for submitting data to Clinic Lite. I'm not going to get into the details of these, but there is an e-file submission option, which is using a vendor abstracting system. And CIHI has also just launched a web entry tool, which is an easier way for clinics to submit data to Clinic Lite. And it's through a web-based form that CIHI can make available to any clinics that are interested. And before I pass it back to Lynn, I'm just going to give you a quick update on some of the projects that we have ongoing with NACRS Clinic Lite. So the Canadian Association of Pediatric Health Centers, or CAPC, is currently using the tool to capture their pediatric rehab reporting data. So there are 6 organizations participating across Canada, and these are pediatric rehab clinics. Most of them are associated with hospitals. They are looking to start submitting data this fall, and some of them will be leveraging the web tool that I had told you about in the last slide. We have another Ontario-specific proof of concept ongoing as well. So this is the first time that we're going to be capturing data on ambulatory rehab care in Ontario. We've been working with the Ministry of Health and the Rehab Care Alliance, as well as various other partners, such as the LINs, to define the data set for this group of clinics. So it's outpatient rehab clinics, so affiliated with hospitals, as well as community physiotherapy clinics. We've landed on the minimum data set. So it's the 17 mandatory data elements in NACRS Clinic Lite, as well as a few of the optional ones that apply to them, and a number of special project fields. In the future, we're going to be expanding this pilot to additional clinic types with their own data sets, and these will include specialty clinics such as cataracts and GI, those performing cataracts and GI procedures. Okay, and I'll pass it back to Lynn.
Okay, thanks, Anne. So I'm actually going to ask you to kind of shift your mindset right now. So we just looked at a data standard that CIHI developed. It's a pick list of sorts, and Anne explained it much better than I do. But now we're going to look at an actual clinical assessment system. So we're talking about multiple assessments that are captured at the point of care in different settings, and the information that's captured once can be used for multi-purposes. And we'll take a look at them through an example. So the assessment system we're referring to is the interRAI assessment system. And we're going to talk about our partnership with interRAI. So where Anne gave you an insight into a data standard that CIHI produces, this is an example of where CIHI is working with another organization to support a data standard. So it's the interRAI assessments. They're used in mental health, home care, and long-term care. Actually, they're used in multiple settings. These are the current settings that CIHI is supporting, and I'll give more detail about that shortly. The interRAI is an organization that's comprised of researchers and clinicians. They exist or have implementation of these assessments in over 30 countries. They're a nonprofit organization. All of the assessments have been based on international evidence. So there's a science to it. They're research-based products, and CIHI works with them to Canadianize them and get jurisdictions across Canada set up with implementation. So what is the interRAI standard? And when I refer to the interRAI standard, we can be referring to the interRAI standard used in home care, long-term care, in an inpatient mental health setting, in a community mental health setting, and so on. So it's that collect once, use many principle. It's clinical assessment first that captures clinical information at the point of care. But in addition to that, the clinician can use the information that's captured to support their clinical decisions, so to do care planning for that specific client they're assessing. But that same information can be aggregated and used to support decisions made at the organizational level and beyond that at the health system level as well. So we recently worked with NRAI to have 10 of these assessments designated as the Canadian approved standards, and this was achieved in 2014 through the Standards Collaborative, which was coordinated by Canada Health InfoA. And I wanted to highlight a success, actually, that the NRAI standards were a part of. Ontario Shores, they're a public hospital in southern Ontario. They're a Centre for Mental Health Services. They achieved a Level 7 standing, which is the highest standing with HIMSS, and they are the Healthcare Information Management Systems Society. So they achieved full electronic use of or movement of their health information within their facility. And the RAI mental health tool was actually part of that, and that's because the NRAI assessments are captured electronically. So that it helped them achieve that Level 7 status. So we're going to talk a little bit about the assessment system itself. So each of the assessments, even though they're created to serve a specific population, they are designed to work together. So what that means is, as you're collecting information in one setting, it uses a common standardized language that's similar in each of the other settings. So for example, the way pain is assessed in home care is the same way the pain is assessed in long-term care, the same way it's assessed in the community, the same way it's assessed in mental health. So as a person transitions between different healthcare settings, their information can move with them, and clinicians understand what information is being captured. So if they generate a pain scale score of 2 out of 3, the clinician who did the initial assessment in home care passes that information on to the long-term care facility. They understand what that 2 out of 3 means. So it's establishing an integrated health information system. And what that looks like more closely, I'll just kind of orient you to the slide. If we start with the person in the middle, so that's the person having the assessment done, and you move towards the right, that's the type of information that's being captured. So you're capturing clinical and functional information. And in this information, actually, I should add that you're capturing the diagnostic information that also uses another standard, the ICD-10-CA, so that same diagnostic standard that Anne highlighted that is used in the NACRS Clinic Lite tool. It also captures demographic data, administrative data, and treatment and service data as well. As a result of all the information that's captured, because this is done electronically, what NRAI has done is they've built algorithms in the background. And as a result of what's captured on that one individual, it generates a series of outputs. And that's what you see at the bottom right-hand screen. There's 4 main outputs that are generated as a result of one assessment being completed. A number of these outputs can be used for direct clinical care planning, and then some are used to support organizational decisions. So the first one, the outcome scales, that gives you an overall clinical picture of what somebody looks like. The CAPs, or clinical assessment protocols, those are actually a set of standardized protocols. They're based on evidence that help zero in on what the problem issues are for that one individual person. And then NRAI produces a manual that provides guidelines on how to provide care for that person. It's not something that's brand new to clinicians. Clinicians have done this all along. It's part of their training to do care planning. But what it does, it's standardizing. And in some instances, it's maybe highlighting things maybe the clinician hadn't thought of on how they can provide that direct care. The last 2 outputs, the quality indicators and case mix systems, those are aggregate level outputs. So the quality indicators help improve or can be the base for some quality improvement programs. They can help highlight where the quality areas are within a particular region or facility, and they can design some program planning around that. And as you move across the bottom of the slide, that's what you're seeing, the multiple uses of that information. So at the point of care, at the organization, and then at the last, at the system level. And here's where your case mix systems come in handy as well, because you're grouping people in similar resource use. Some provinces have even implemented them as part of their own funding models. Ontario and Alberta are examples of that, where they've implemented the RUGs, which is the case mix system used in long-term care as part of their funding models for those provinces. And then, of course, CIHI at the top, we get the data last, but the value add for us is we provide that pan-Canadian comparability that you can go in and see how you're doing, compare yourself to other regions and benchmark according to that. Find your peers and see how you're doing. Here is a list of the reporting systems where we collect that information, those NACRS assessment information in. So we have 3 reporting systems currently that we support. The continuing care reporting system, so those are all the pink stars across the country. That is information on the RAI-MDS 2.0, so that's the NACRS assessment that's used in the long-term care sector. The green stars are reflective of the home care instruments, so you have your RAI-HC, your RAI home care, and in some instances it's also capturing a tool called the NACRS contact assessment. That's a screener that home care organizations implement in order to help differentiate if somebody needs home care services or not. And I also want to highlight here, you can see the wide span across Canada, but Alberta, they also have 20 First Nations communities who have implemented the NACRS or the RAI-HC and the NACRS contact assessment with plans to expand. And First Nations Canada is also currently doing a business case to see how they can expand the use of these tools across the country. And our last reporting system is supporting the RAI mental health tool, and that's called the Ontario Mental Health Reporting System. We don't have as wide coverage at this time, but I'm sure anybody in the healthcare field knows that mental health is certainly a priority across Canada, and we do expect to see greater uptake of those instruments in the coming years. And what we're going to do now is I'm going to hand it back to Anne, and what Anne is going to do, she's going to walk through its story of SAM, and we're going to use SAM to demonstrate how the 2 standards, so the NACRS Clinic Lite and the NACRS assessments, and we're going to focus in on the home care assessment, how they can use to support his care and others like him. So, Anne, I'll hand it back to you.
Great. Just really quickly, we have one question on the panel, if I may. Somebody has asked, what is the diamond in SK on the CIHI interRAI data standard reporting map?
That is something I forgot to remove. I'm just seeing it now. What it refers to, they are currently collecting, but we're waiting to get it in. So it's in production, like they're working at it, but CIHI is not currently collecting their home care data. And I'll have to edit that slide after. Thank you to whoever pointed that out.
All right, thank you.
Great. So we're going to introduce you to Sam. Sam is a patient. He's a 76-year-old widower who lives alone. He has type 2 diabetes and hypertension, and he's just developed a new open wound on his lower left leg. So as Lynn said, we're going to explain to you how Sam's data gets used and filtered into CIHI, and the way that data can then be used for both clinical decision-making and planning purposes across the continuum of care. So we'll start with the NACRS Clinic Lite or ambulatory care data holding. So Sam, as you know, he has diabetes, so he visits his local diabetes education center, which is the type of outpatient clinic, for a group session on type 2 diabetes. Following his visit, the clinic submits an ambulatory care record to CIHI, to the NACRS Clinic Lite data holding, which I spoke to you about earlier, with the following information. So the data identifies who Sam is, so elements like the healthcare number, gender, and birth date do that. Where Sam came from, so we get data like his postal code and the province or territory issuing his health card number. When Sam visited that clinic, so the fiscal year, the date of registration, what brought him to the clinic, so there could be a pick list based on ICD-10 codes, and what services were provided to Sam. So the reporting facility and the mode of visit are examples of data elements that would answer that question. So over time, as more data is gathered, there are trends that will emerge on, and not just on Sam's data, but all of the different patients that have data provided into the system. We'll be able to use that to see trends on the demand and use of the Diabetes Education Center and compare that to others across the country. We can look at the demand or use of services provided by the Diabetes Education Center, and some of this data will need to be collected through the use of various data elements in NACRS. So special project fields are an example of where the record can be further customized to gather some of this information. We can learn more about wait times for services provided by that clinic. We can learn more about readmissions, and lastly, we can start to see some trends on demographic variations in patients that are going to the different diabetes education centers across the province and country.
One question on the panel, if I may. It's a question from Laurel, and she's asked if there's any, she asked it a few minutes ago, so Laurel, please speak up if we're not addressing your question properly. But she's asked if there's any consent required.
So is this specific to interRAI or just in general?
Laurel, you might have to take yourself off mute. If not, we'll move on. Laurel?
It's Lynn. I can answer from the NRI perspective. So when somebody...
actually, sorry, she's just typed in, yes, consent from the patient, but Laurel, if you can let us know if your question is related to interRAI or what they were speaking about just before that. Laura, I think everyone's unmuted, so feel free to speak.
Oh, okay. Can you hear me?
Yeah, we can hear you.
I thought we were all on mute, and I was trying to unmute. No, I just wondered if there's any kind of consent. I mean, this is amazing, but does Sam have to consent at some point is what my question is.
Yeah, with a clinical assessment, he would have to consent before the clinician moves on. So it's just a different way of capturing the information. So if you think of yourself going in the physician's office, you're consenting when you're going in, and you're consenting, you've booked the appointment, so the physician's doing an assessment on you. And before he was writing notes, now he's capturing it electronically. So in the clinic, the physician's capturing it. Part of that capture is using the NACRS Clinic Lite as they're moving, and we're just going to talk about Sam now getting set up with home care services. So he's agreeing to have home care services, and part of that is the assessment process. Does that help?
It does. If we start to share Sam's data with other healthcare providers, how does that impact consent? Does he have to consent to that? I just feel like that's what's holding up a lot of the EMR issues.
Yeah, and that's actually, it's a very good question, and I can't speak with respect to different jurisdictions' business processes. I'm not certain on that, but you're absolutely right. That is a factor when it comes to moving that information electronically.
Okay, thank you very much.
Thank you. All right, so if we think of Sam, and he was just in the clinic, and he has that wound, and they think he needs some nursing services, so they've called into their local home care agency. The case manager at the other end of the line, what they're going to be starting on Sam is an interRAI contact assessment to assess if he needs or qualifies for home care services, and this may differ depending on the jurisdiction you're in, the business processes around that, or the eligibility criteria. But what that contact assessment gives the assessor is information. It's a different type of assessment. It has a different purpose, so it generates different outputs. And two of those outputs are an assessment urgency score that helps inform the home care staff if Sam needs a more comprehensive assessment done, such as the RAI home care, and as well as service urgency score. So how soon should we get those nursing services into Sam to have some wound care done? So Sam actually does require a RAI home care assessment. So a clinician or a case manager, depending on where you are in the country, whatever assessment process you have set up, goes into Sam's home and completes a RAI-HC on him. And as a direct result of that, the clinician's inputting, and in real time, they press a button, however that their vendor chooses to create that software for them, but they'll get the information back in real time, and what they'll get is SAM's outcome scale scores. And I've just highlighted 2 here. So we see Sam has a pain scale score of 3 out of 3, which is indicative of him having severe daily pain. And he also, I've highlighted his depression rating scale score. So what that is, what interRAI has done is they have this scale, and it's been validated against other well-known scales for depression, so the Cornell Depression Scale. But what it does is a score of 3 out of 4 indicates possible signs of depression. So here we see Sam has a score of 6 out of 14. So he potentially has issues with depression. So it's giving that clinician the overall clinical picture of Sam, and it helps them formulate on how they're going to care for Sam. The other thing they're getting
someone has asked if there's a specific consent required to move patient data from one facility to another.
I can get back to that person, and it might depend on jurisdictional business process. If there's an actual signing of a consent. I used to work in home care in Ontario, and it was when you when that person was consenting to home care services, it was part of that.
Okay, so we can always follow up afterwards. Thank you.
Yeah, okay, thanks. So the other output that is generated in real time for the clinician is the client assessment protocols, which I think I made a typo there. It's clinical assessment protocols, so I apologize for that. And again, they flag areas to support SAM's care. So we saw that he had a depression rating scale score of 6 out of 14, and one of the CAPs that were triggered is a mood cap. So the clinician can refer to the CAPS manual to help guide how they're going to intervene for SAM to address this area. So this actually highlights that movement of information. So we won't focus on the consent part. We'll get clarification around that. And then again, it may differ among jurisdictions what that actual process is. But the fact is that the information can be moved, and the RAI assessments, I didn't mention earlier, when the RAI assessments were developed, the original versions, you have your RAI in the long-term care sector, your RAI in the home care sector, and RAI in mental health. Those have all been updated, and they're called the new suite. And so, for example, the RAI-HC is now, the newer version is called the interRAI-HC. There isn't great uptake of it yet, but it's new, and jurisdictions are starting to transition to the newer versions. But with the older versions, you have this option of personal health profiles, and what they are they're summaries. So the RAI assessment is a comprehensive assessment. It's 9 pages, depending on what sector you're in. So it's a lot of information to pass on. So they actually summarize them in 2 pages. And depending on who you want to send it to, it pulls different information. And here's an example where you can send that information to a primary care physician. So you can send that summary, and they can get a synopsis of what that assessment captures for you. And that would be done through a portal, through faxing, through scanning. And again, you'd have to look into the privacy issues around that. So here's another example of how SAM's information can be moved. If you take his complete assessment, and it can be shared between a portal, and this would be a secured portal that another user can go in and access his information. For example, Sam had a home care assessment done in Ontario. Currently they have that intermediary, the CCACs are the intermediary body, and they contract out the nursing services, so the nursing provider can go into that portal and capture SAM's comprehensive assessment and see that type of information that was initially gathered. So they're not having to redo that assessment, that it's already been done. A similar process is in Ontario, and I believe also in the Western provinces. Part of the eligibility criteria to get into a long-term care facility is the completion of a RAI home care assessment. So again, that would be shared with the long-term care facility through a portal environment, and it's a way of moving the information. here's an example now. We've focused in on how STAMS information can be used at the clinical level, and we talked about how the NRI assessment information can be collected once and used for many different ways. So here's an example. If we take STAMS depression rating scale and we combine it with everybody else in his region, it gives his home care organization an ability to look at what depression looks like within their region itself. So the female is the blue column, the male the orange column. I had mentioned earlier how a scale score of 3 or more indicates possible signs of depression. So if we look at the 3 to 4, there's a significant increase in male with the lower signs of depression, but once we move into those higher signs of depression, there's actually a higher range of, a higher amount of the female population in this particular home care region is demonstrating signs of depression. Other uses, if we look at the quality indicators, so we talked about outcome scales and CAPS. Now we're looking at quality indicators. There's examples of 3 of them at the bottom of the graph, so along your x-axis, the prevalence of negative mood, prevalence of social isolation, and prevalence of falls. Then we have 3 different regions so that you have the ability to compare yourself, and then compare yourself against the provincial average. And if we look at region A, so they're the lighter blue column, they have a higher rate of negative mood and prevalence of falls than all their 2 peer regions, as well as the province. So that might highlight for them, are we having issues in this particular area? Why do we have that higher rate? And it might spur on some quality improvement initiatives, or even spur on them to reach out to their peer organizations and ask, what is it that you're doing that you have lower rates? It just starts the questions and provides that ability to compare. And the last example we're going to look at of using the information at the aggregate level is using the MAPLE scores. So STAMS Home Care Organization can follow trends of measures that predict risk of transitions in care. So the MAPLE score is one of those scales that's calculated when a RAI home care assessment is done. And what MAPLE stands for Method of Assigning Priority Levels. And what it does, it's an indicator for risk of institutionalization. So what the region can do is they can see how much of our population is at risk for that transition of care to an acute care facility, to a long-term care facility. And if we look at this particular region who's pulled their data, if we look at the 2014-15 and you focus in on the light blue line, which is the very high need, so it's those people who are at very high risk of institutionalization, and the one just below that, the red line, they're both on the rise. So that might highlight something for that region to look at, what's going on with our population with respect to their risk levels transitioning outside of the home care population. And maybe I'll stop there for any questions about the NRI assessment information.
Okay, we have quite a few, so I'm just going to read them out. I will be identifying the people that ask in case more clarification is needed. I also just want to share that we have about 15 minutes left, so we might not be able to get to all the questions if there's a little bit more content or some discussion. So the first person's question that we'll address is Anjem Ahmed, and his first question is there clinical alerts or notifications workflow as part of the assessment? Assuming if a pain scale exceeds a threshold, does a clinician or nurse get notified? And the second part of his question, or their question was, actually let's do that question first and then we'll come back to the second question.
All right, well as the clinician is doing the assessment, they're actually getting that information in real time, so they would see it. With respect to alerts or how they use that depends how the vendor builds their software, and the organization in their RFP process might request specific things like that, but it is a real-time look at the generation of those outputs. So they would see the information, then it would be up to the clinician then to follow up care and share that information with the care team.
Another question came through from Vera, who owns Database behind the portal. If there are several sources of information, when it all gets into one database, who maintains it?
Sorry, can you repeat that?
Who owns the database behind the portal? If there are several sources of information, when it all goes into one database, who maintains it?
Well, it would be, and I'm just thinking of Ontario's process when we used to use the portals for transferring the information. It would only sit in there for so long. So the portal was a shared software or a shared tool between the home care organization, or it was set up by the home care organization. And the assessment only sits within that portal for the other, whoever's accessing it, for a specified period of time, so say 24 hours. And then it doesn't sit there anymore, so it's not a repository. The portals are not repositories. Now in Ontario, they do have repositories where the NACRS assessments are stored, so the Integrated Assessment Record, and that's a provincial system.
Okay. There is another question. This one's from Anne. Is the described portal where the interRAI data is held part of a, well, this is actually maybe part of the same question here, part of a prescribed data registry or simply acting as a service provider? Is there a reporting feature for accessing aggregate information, or is the data only available to each individual provider?
Yeah, the portal isn't used as it's simply to transfer the information for that specified period of time. The integrated assessment record, so the provincial tool, it can have capabilities, but they haven't tapped into that yet. So currently it's only functioning as a repository. But there are other, there's a clinical document repository they're looking at within Southern Ontario, that there are talks about using those types of instruments for that reporting feature, and we'll get into it. That's when we're starting to look at the actual interoperability of the NACRS assessment information, and that's our last few slides.
Okay, so we'll hold, there is a question about interoperability in terms of SAM's assessment information going to its EHR, so maybe we can hold that. And there was another question about consent, and that's from Charlene, but Charlene, I think we'll may need to answer your question offline as we have only a few minutes left. Okay, back over to you, Anne and Lynn.
All right. I had a colleague, he just reminded me, CIHI does have a public website. It's called yourhealthsystem.ca, and we collect and share that information on the quality indicators. So there's 9 quality indicators from the long-term care tool that are publicly reported on there that you can go in and actually see facility-level information. And so there's another example of where the information can be shared. All right, so just the last piece, we're going to talk about potential for the future. And we've talked about the assessment information, the NACRS assessment information being captured electronically and that it can be moved in its entirety through these portals, but we still haven't achieved what's called full clinical interoperability. And a number of people on the line might be familiar with what that is, but what it looks like is in New Zealand, they've actually done this, and it's new for them as well, but we're very keen to see how it unfolds in New Zealand. And what it means is they have cross-country implementation of the NACRS assessments in the community sector, the home care sector, and long-term care sector. And what they've done with these instruments is they've created full HL7 CDA compatibility. So they've written the messaging standard that align with the NACRS assessment standard, so they can actually move pieces of the NACRS assessment as opposed to it as a full clinical document. And it gives that more flexibility in accessing the NACRS information. How they're going to use it, we're not sure yet. So it's new for them, they've achieved it, but what does that mean for Canada? What we're currently doing is we're in discussions with NACRS, and we've agreed to move forward in working together to look at establishing the HL7 standard with the NACRS assessments. How that's going to happen, we're not sure yet, but we have agreed to move forward with it, which is quite exciting actually, but it's still a lot of work to be done. So we still have to scope out working with clinicians to see what that exactly will mean. So to look at the full potential of what access to this information provides. And there's just a visual up there of what it potentially could provide. So you have Sam on the left-hand side of the screen who's had his assessment completed. If that full assessment can be moved into an electronic health info record, and then on the right-hand side of the screen, you have different opportunities to pull that assessment information into their own EMR, so that ambulatory care clinic where Sam actually started, or if he has an admission to the emergency room, or if he has some other community services, that ability to move the NACRS assessment information would be possible if we created that messaging standard for them. And then with that, there may be potential ability to move information from the EMR back to the NACRS assessment standard. We're not sure yet. We're just at the beginning stages, but it's quite exciting actually. And we are keeping an eye on New Zealand, and we have quite close contact with them to see how they're going to move forward as well with the possibilities around accessing the NACRS assessment information. And that's where we'll end. And Anne, you have some contact information up on the screen.
Yep, so if anyone has any follow-up questions or wants to learn more about NACRS Clinic Lite or interRAI, you can contact us with the information that's available there.
And the same with if you have any questions around the NACRS assessments. I'm certainly not the holder of all of it, but I'll be sure to lead you to the appropriate people within the organization.
We've also promised for the participants on the call, I will be sharing the full sort of transcript of your questions that have come in with our presenters today. So if they didn't get a chance to answer your if they didn't get a chance to address your questions, I'll be sharing that with them and they'll be in touch. Lastly, if there's no other questions, I don't see any others coming in, but you have a few more minutes to send them in, and then, again, you can reach us all by email. I'd like to share a little bit more information with you on Digital Health Week, of which this webinar is a part of. It runs until the end of this week. There's a number of other presentations going on. I'd encourage you to visit betterhealthtogether.ca to see what those are and to register for them. There's also a social media campaign that encouraging people to think digital health, and there's a bunch of badges and things that you can get off on the site and post to your individual networks. I'd like to thank Anne and Lynn again for a very informative, interesting, and definitely an interactive presentation today. We've got a whole bunch of people on the call and some very good dialogue in the chat function, so we appreciate your involvement in Digital Health Week, Anne and Lynn, and of course CIHI, and I wish you all a very good afternoon.